Good morning. Welcome to good afternoon, actually, for most of you. Some of you are still in morning. Welcome to the webinar on COVID-19 testing technologies in Canada. My name is Yoav Kainan, and I am an infectious disease specialist and researcher and associate professor at the University of Manitoba and the scientific director of NCCID, and I will be your moderator today. NCCID is funded by the Public Health Agency of Canada to provide knowledge translation and evidence to public health planning and policy. Before I begin, I would like to acknowledge that the NCCID is standing on and located on original lands of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people and the homeland of the Métis Nation. There are a few housekeeping notes that I would like to mention before we begin. We're running the webinar on Zoom, and if you have any problems, technical problems with the Zoom, please contact us through email to nccid@umanitoba.ca. We will do our best to assist you. The presentations you will hear today are pre-recorded. Following the presentation, we will have live questions, and we hope that we can accommodate as many questions and answers as possible with our speakers. Please use the Q&A box to submit your questions to the speakers and at any point during the presentations, and we will have to discuss those at the Q&A portion of the event. You can like other people's questions, and that will vote them up in priority, so we will try to address those that have received popular demand. The chat function will be disabled. Resources from today's webinar, including the recording and presentations, will be available at the NCCID website next week. The objective of the webinar is to provide an up-to-date information for healthcare professionals on the latest on COVID-19 testing technologies, to share local experiences on tests at the ground level, and to provide an opportunity for engagement in questions and answers related to testing and testing technologies. The webinar is composed of two components, two parts. The first part, presented by Dr. Poliquin, will focus on the latest COVID-19 testing devices and technologies and their applications and limitations. The second part will highlight local experience with COVID-19 testing technology at the ground level and is presented by Dr. Pawa. I would like now to introduce our speakers before we move to the presentations. Dr. Guillaume Poliquin is the acting Scientific Director General at the National Microbiology Lab. Dr. Poliquin has completed his medical degree at Western University prior to pursuing pediatric residency, and then followed by a fellowship in pediatric infectious diseases, both at the University of Manitoba. He has then joined the microbiology laboratory for special pathogen divisions for his PhD focused on Ebola virus. He has since assumed the role of medical advisor to the Scientific Director General at the NML and is now acting as the Scientific Director General. Dr. Poliquin continues to have an active pediatric infectious disease consultative practice in Winnipeg, as well as a general pediatric practice in remote communities in the north, in Manitoba and Nunavut. His research portfolio is focused on vaccines, emerging pathogens such as Ebola, and recently SARS-CoV-2. Dr. Jasmine Powa is a public health and preventive medicine specialist and physician based in Toronto, Canada. She works as a public health physician consultant to a range of public health sector organizations and provide a medical officer of health locum services. She's the president of Public Health Physicians of Canada, and her teaching commitments include co-leading the public health theme for undergraduate medical education at the University of Toronto. She has completed medical school at the University of Alberta before moving to Toronto for her public health residency training. She holds a master's degree in health policy from the UK jointly from LSHTM, and her professional focus is health policy and health systems. With that introduction, I welcome our guest speakers, and we'll start the presentation.
Greetings, everyone. So I'm Guillaume Poliquin. I'm the Acting Scientific Director General for the National Microbiology Laboratory of the Public Health Agency of Canada. And it's a pleasure to be here virtually with you today for this testing technologies seminar. So what I'm going to be doing today is going through some of the COVID-19 testing technologies to give a sort of a foundational understanding of how they work and what they're actually measuring. It's a complicated and fast-moving field, so we'll start with developing sort of that common understanding of where the technologies are and what they're contributing. And then I'd like to take a few minutes to go through essentially a case study, if you will, about why understanding the testing technologies and how they work is important. And we'll do that by talking about a fairly topical issue of the day, which is the rise of variants. I think it's important to understand how we're looking for those variants and how that affects testing technologies overall. And then after that, pass it off to Dr. Powa to take us from there. So today we're going to be focusing on the Rtpcr, probably our workhorse, and then we'll talk about point of care tests and what that means. We'll delve into antigen detection, which has certainly been very much in the news as of late, and then briefly touch on serology and what sequencing means. And then we'll get into that sort of case study, as I mentioned. So what is PCR? PCR essentially is a method by which we are looking for the genetic material that makes up the SARS-CoV-2 virus. And we are looking for a very specific piece of it that's then amplified over and over and over and over in order for us to be able to detect it. And that's what this little graphic represents. So this is the ever unpleasant nasopharyngeal swab that is being performed, and that's our sample collection method. Many of you will be familiar with alternative methods of sampling, either an anterior nasal swab or more recently saliva or the so-called swish and gargle technique. All of those are just different ways to collect what we're looking for, which is the SARS-CoV-2 viral particles. That then feeds into the PCR test, where we first have to process the sample, sort of extract that genetic material, and then the PCR reaction starts. And this is where you can see graphically, we're sending a little primer, which attaches to the SARS-CoV-2 DNA if it's there. And then the chemistry of the test start, and we essentially make a copy of the genetic material. And then that is replicated over time, usually about 30 to 40 cycles. And if there is genetic material of SARS-CoV-2 present in the sample, eventually there's enough of the material that we're able to detect it. And that's shown here, where all of a sudden it crosses that threshold of detection. PCR is the gold standard for the diagnosis of COVID-19. And the reason for that is because you're able to actually pick up even very small quantities of the virus. So if you're early on in your disease, or if you're sort of in the recovery phase, the test will still work. There's a few challenges sometimes in terms of the interpretation, particularly early on or later on, but overall, the PCR has become our sort of core gold standard, and we don't expect that to change, certainly not in the short to medium term. It's important to note that some of you may have heard over the past several months that there's been supply challenges sometimes in terms of the various pieces that go into the testing, and that's something that's fairly closely monitored to make sure that we have more than one technology that is able to do PCR in play. Also, as a point of pride for Canadians, I think it's worth mentioning that the National Microbiology Laboratory was able to develop the first generation PCR test to detect SARS-CoV-2 within 5 days of the sequence being published by Chinese researchers. So that's fairly impressive, at least in my mind. So then moving on to the other technology that's been in the news quite a bit is point of care tests. And I want to just highlight, what does that mean? PCR test traditionally is done in centralized laboratories using fairly technical equipment and well-trained technical staff that are able to do quite a bit of the work. And with that setup, you're able to ramp up testing to do hundreds or thousands of tests per day, depending on the size of your laboratory. But that's not always ideal. If we think about northern, remote, indigenous communities, where a travel time to a laboratory can be quite long, that it can be very difficult to get a timely result. And so that's where point of care PCR technology is particularly attractive. So it's essentially a lab in a box. You see here, there's two pictures. One is a BioFire instrument here on the left, and this is a GeneXpert device. There's a few others that are authorized in Canada as well. But in essence, these devices, you put the test sample into a pouch or a cartridge, put the cartridge in the machine, and then the machine takes over and does sort of all of the steps within that machine and gives you the interpretation of the test. Really, really helpful in those sort of northern, remote, indigenous regions. Also helpful in a few different ways. For instance, if you need a test right away for someone that's had an accident and needs to be rushed to the OR, for instance. The downside, though, is that the supplies of those cartridges are quite limited overall, and the throughput is quite small. You can see here on the Expert device, for instance, there's only 4 spots for a cartridge, so not suitable to do widespread thousands of tests a day, but in their environment, they are ideal environment, they are excellent devices. The other very topical device has been the Abbott Id now, which is a good way to think about it is that it's PCR's cousin. And the reason for that is that while they are both molecular tests, and by that I mean they are looking for the genetic material of the virus itself, it uses a slightly different chemistry. That means that the device is a little bit less sensitive and less specific than the gold standard PCR, but that is sort of balanced by the fact the test is a lot more rapid. You can get a positive result in as short as 5 minutes and a negative in about 13 minutes. So very, very quick, super easy to use. In this case, there's even fewer steps. You literally take the swab and you put it straight into the machine for processing. So it's a true point of care device. The downside is that you can't actually ship the sample to a machine. You have to have the machine on site. So, but overall, it's a new technology that's certainly gaining some wider use. Moving forward away from molecular tests now and talking about antigen testing. Antigen tests are detect for the presence of the virus, but not the genetic material, the actual proteins that are part of the virus. And so that makes them really, really user-friendly. You can see here, this is an example of sort of a generic looking antigen test, and it's very conceptually very similar to a home pregnancy test. There is a mixing step though, because you have to take your swab, put it in the liquid, and then put the liquid onto the device as you see here. And then 15 minutes later, you get a positive strip or a negative result. There's some that you have to read by eye, literally like a home pregnancy test. And there's a few that come with dedicated readers that help with the the interpretation of the test. They're quite cheap and they're really easy to perform, so they have many advantages going for them. But they are not, there's no amplification step like we see with the molecular tests. So as a result, you are dependent on having a really high or a high viral load at the time of the test being done for us to be able to detect it. What does that mean in real life? Well, that means that if you're symptomatic or you're early on in your disease process and your viral load is sort of at its peak, the tests actually work really, really well. They're comparable to PCR tests. But if you're a couple days outside of that ideal window, or you're really, really early in your incubation period, the tests don't perform as well. So they have to be used with a bit of additional guidance around them so that they're interpreted correctly. Speaking of which, so there's a number of guidance documents that have been put out. This is a guidance algorithm that was put out by the Public Health Agency of Canada that helps to sort of guide you through the interpretation of antigen tests. There's some provinces and territories are developing their own guidance. So would encourage any healthcare provider to look through their own jurisdiction's guidance. But this FAC guidance is available on the web, and you can see the address at the bottom of the slide. I will say that this is an interim piece of guidance, and it's periodically being updated as data comes in about these tests from a variety of clinical settings. Moving on to serology fairly briefly. So serology actually does not detect the presence of the virus itself. Molecular tests, antigen tests look for the virus. Serology looks for antibodies that that individuals who've been exposed make against the SARS-CoV-2 virus. So by definition, there's a bit of there's a time lag, because you have to become infected and then your body has to respond. There's a few different classes of antibodies and they respond at different times. But in general, it takes at least 4 days before we can start to detect the IgM antibodies, so those first ones that come up. And then the IgGs trail behind, and it can take up to 3 to 4 weeks before antibodies are reliably present, depending on different individuals and different clinical exposures. So this is really useful if you're trying to study population dynamics. It's also really useful in cases where we think someone may have sequelae or consequences from a previous infection, and we're trying to diagnose an infection that happened in the past. It's not useful, however, for day-to-day diagnostics because of that time lag. And then finally, I wanted to touch on sequencing, because sequencing has been in the news quite a bit with respect to the variants. So this is a very brief primer on what that means. And so sequencing really is looking at, it's a sort of a more extended version of a molecular test. And the way I think sort of illustrates the concept is when we're looking for the virus by PCR, it's essentially identifying SARS-CoV-2 like a book by its cover. You get little bits and pieces and you line them up and you say, okay, yes, that is SARS-CoV-2. When we're doing sequencing, we are reading the whole book from end to end, and you get all that information. And so that's, we can use that information, that broader information, to learn more about the virus itself. So one way you can use genomics is by being able to say, okay, how is the virus spreading through a community? Because as it spreads, so here you see someone gets infected, they have a number of different versions of the virus. They then infect other people either with that version of the virus or one with a slight mutation. And then that mutation then carries on to other people. There's a second mutation that happens, and now you have a different version. And by putting all that information together, you can get a really good sense of how a virus might be transmitting in the community. This is also how we look for variants. And variants, we'll touch on in a second, are in order to detect them reliably, you need to have that full genome. And so that's why sequencing is so important as we move in this next phase of the pandemic. Variants of concern, it really put the various technologies in context, and why understanding a bit about how they work is important. So what we mean by variants of concern is we're looking at new versions or new mutations within SARS-CoV-2 that potentially change the way the virus behaves. So that could be increased transmission, it could be increased virulence or disease severity. It could also mean that it becomes more difficult to diagnose because the changes in the target of the various tests, or it could change in such a way that vaccines or previous infection don't protect you as much as they would have otherwise. And so that's something we're tracking very, very closely through a number of different tools. But when we think about the impact of variants on testing, we can think about it in this way. So a mutation that changes the little snippet that the PCR is looking for can actually make it so that the PCR probe doesn't bind anymore. And so we're looking for it, but the PCR has become blind, so to speak. The good news about that is that most or almost all tests in Canada use at least 2, if not 3 different little pieces or little targets. So if we lose one, the test still works because the other 2 are functional. But it's important for us to think that through. And if you're in a clinical scenario where you're seeing someone where you really think they have SARS-CoV-2, but the tests are coming up negative, then that's something to flag because we may need to have a look at what's going on. The PCR cousin, the Abbott Id now, or the LAMP-based assays, they use not 2 to 3, but actually 4 to 6 different targets. So they are also quite a bit less vulnerable to variants of concern. Antigen tests, on the other hand, most of them target a protein that's that doesn't change much in SARS-CoV-2. It's one of the proteins that is sort of necessary for it to replicate adequately. So so far we haven't seen any mutations that would affect that part of the region, but in theory that could become an issue in the future. So something we're watching. Serology, on the other hand, tends to actually target the outside portion of the virus, that so-called spike protein. And so far, a lot of the mutations we've seen in variants have affected the spike protein. So in general, serology tests may be more vulnerable to variants of concern. But as we pointed out earlier, they're not used in day-to-day diagnostics. So the overall impact is fairly limited at this time. And then finally, sequencing, because it reads the whole genome, is looking for those mutations. So the presence of variants of concerns are detected by sequencing and aren't really the sequencing process isn't really impacted. So that hopefully is a helpful overview of how the various technologies work and how they add to our ability to detect SARS-CoV-2. And with that, I will pass the presentation over to Dr. Powa, and then we'll be back at the end for questions and answers. Thank you. Merci.
Dr. Powa.
So get started. Thanks so much, Dr. Poliquin, for the presentation. My name is Jasmine Powa. I'm the current president for Public Health Physicians of Canada. Thanks for the opportunity to be here today and present, and also thanks to the team at NCCID, the National Microbiology Laboratory, and the Public Health Agency of Canada. I'd really like to acknowledge the support of colleagues who shared their thoughts for this presentation. Many of the thoughts are theirs. And also acknowledge that we've had many personal and professional adaptations through COVID this past year, and it's been tiring. And I know people are working really hard to observe the guidance, and we still have a ways to go, but there's hope and more work on the horizon. I don't have any private sector interest to disclose. In terms of roles, I'm a public health and preventive medicine specialist physician, and I do contract work for a number of public sector organizations, alongside my work with Public Health Physicians of Canada and some work in teaching and other areas. A brief note on PHPC. We're the specialty society for public health physicians, and many of our members are medical officers of health who've been with responsibilities for overseeing the public health response to the pandemic alongside our broader scope of public health practice. And I've put a screenshot here of our website and some resources there in case of interest. So the goals today, I think I'm hoping to share some information needed and that may be helpful for how we make decisions around how we use this testing and where it fits in. There's a lot out there and a lot of discussion about testing, and it's a really important part of the response. But one part of the response, and it fits into many other pieces in our system for the public health and healthcare response to this pandemic. So I'm hoping through the discussion today we'll be able to talk about a few frameworks, tools, give some examples, and then have a fair bit of time for questions and discussions at the end. So Dr. Poliquin described a range of technologies that we can make use of, and this changes sometimes daily, weekly, and beyond. So a lot of questions come up around what's most appropriate to use and when, how do we do this equitably, how do we do it efficiently, how do we do this well, what are the opportunity costs of using some testing technologies over others. So the goal today is to talk about a few tools related to that. Throughout, I'm hoping we can keep in mind that our goals in population health approaches are often twofold, to both improve health outcomes and decrease inequities. And specifically for the COVID-19 response, we're working hard to minimize overall illness and death while also minimizing the societal disruption due to the pandemic and its response. There's a few things that run as a layer of everything we're talking about today. So we've talked a bit about how public health is about much more than communicable disease. It's very different to one-on-one healthcare services. So there's a piece there. And preventing the exposures in the first place is an even more upstream way of us containing this pandemic. With testing, I think keeping in mind that it fits into this chain around find, test, trace, isolate, support you might hear talked about is really important, because if we don't have the systems in place to respond to our positive results or other places, we aren't going to be as successful in what we're trying to accomplish. So there's many purposes to testing. I'd really encourage individuals, if they're interested, to read this 2-page viewpoint. The information on it's at the bottom of the slide. That tries to pull some of this together and talk about when we're looking at testing for individual level purposes or for diagnostic purposes, what should we be thinking about? And when we're looking more broadly at surveillance and we're talking about wastewater testing or other things, what does that look like? And then we've heard a lot of conversation recently about screening and rapid tests and screening. So I'm going to talk a little bit more about that today. And there's other ways at looking at the reasons for testing. So the European CDC has talked about looking at controlling and monitoring transmission, to detect clusters or outbreaks in specific settings, or to look at how we know we don't have COVID in a certain setting, and comes back to the idea that it needs to remain flexible, able to change and adapt rapidly, and also draw on pieces of expertise within public health and healthcare and laboratory, with all of us working together. So I'm not going to go into great depth around testing performance or the different types of technologies, with thanks to Dr. Poliquin for covering those so clearly, much better than I ever could. I do want to flag that it's important for us to keep in mind both the characteristics the characteristics themselves when we talk about sensitivity and specificity and other pieces, but also the importance of pre-test probabilities and how likely we think someone may have COVID going into that test. And there's some tools available like this BMJ one where you can get a sense of, in different circumstances and different types of test performance, what do you have for false positives or false negatives, and how big an impact is this likely to be? And then that can help us plan our programs. This information also continues to evolve, so we have to be open to shifting what we do as we learn more. And it gets complicated. There's a lot in there, so the estimates may differ if we're looking at academic literature or manufacturers or deployment evaluations. When we think about false positives and negatives, there may be ways we can mitigate any adverse impacts. And all of the above can vary depending on the collection method, whether or not the individual is asymptomatic or at different times following symptom onset if we're in a different setting. So these are all pieces that go into the decisions we make about the use of these testing technologies and the guidance we provide on a healthcare and public health perspective on how they fit in. So here's an example that tries to pull this together. It's from some of the national panel's work that suggests that if somebody's symptomatic or has had close contact, we're looking more at trying to use PCR. If we're in a setting where they're asymptomatic with no known exposure, maybe we should be considering a rapid test and confirming those positives by PCR. And some of the examples we'll talk about have taken an approach like this. So this is one way to do it. This is likely to change. I'd flag, and partly given the role I have in the organizations I work with, of the importance of us being very mindful about expert public health judgment and medical officer of health direction when we're managing outbreaks in particular, and more broadly for the conversation. There are lots of other factors, and this is not mutually exclusive or collectively exhaustive, this list, but when we think about the people doing the testing, how they're certified and trained, the space we're doing it in, that we're following what's needed for biosafety, these are all considerations that are important parts of doing the testing. And I think when we think back to the goals talked about earlier around improving health, decreasing inequity, we know that the pandemic has really surfaced things that we know are there around the disproportionate impacts on certain groups in our societies, around people not being in a position to make choices they might want to make around their health, and that needs to be an important part of our conversation as well. Wanted to make a brief note on two pieces. One was around information systems. So this is a comment from a colleague that I really liked around how an efficient IT system is an unsung hero of this whole enterprise. And I really agree with that, because there's so much data and so much information being shared, and how we share it so that it can meet the public health goals and healthcare goals effectively, while also being mindful of privacy and personal health information considerations is really important. And then the other one noted on the other side is around communications. I think if we do a good job of managing expectations on what these tests can and cannot do and how they fit in, that really helps us in this response as well. So I'm going to talk a little bit about rapid testing and then a little bit about specific settings and screening, because it's what we're hearing a lot of right now. And I think if we did this conversation in a month or two again, it would be different. But the rapid testing that Dr. Poliquin spoke to around, there's many different antigen tests, the ID now, I like the description of PCR's cousin for how that test works. We've been using these in various ways across Canada. So some jurisdictions have deployed them to communities that have longer test turnaround times, things like the ID now for symptomatic testing, for example. Some are using rapid testing in areas with people who are asymptomatic and without a known exposure. And the experience of Nova Scotia in particular has been talked about quite a lot in the thinking around testing as engagement and ways to have it as a way of community engagement in the populations they've been working with. So there's a whole range of examples how we've been using these, and I hope that we can continue to learn from each other for jurisdictions and share materials and share protocols so that we keep adapting and minimize the work on all of our fronts. I wanted to share a positive reflection as well as we talk through this conversation around the pandemic having been an opportunity to expand molecular testing to many parts of the country that would not have had this type of testing before, and that this maybe have a legacy in a positive way for helping us in responding to tuberculosis or pertussis or other illnesses, and that's something we hope we can continue to build on. So the rapid testing, we've talked about a few places it may have a role, and I would encourage everyone to look at the Public Health Agency and National Microbiology Laboratories guidance on the use of antigen testing and some other places. But some settings that come up are congregate living facilities, places that are more high risk or very large settings. There's a lot of discussion around travel and how we do that in a way that makes sense. I think some things to keep in mind are considering both residents and staff in the facilities, considering programs that are periodic repeat testing while keeping in mind testing fatigue, and using less invasive options where we know they're appropriate or that they work with what type of testing we're doing. And then always keeping in mind that testing, the negative test alone is insufficient. We need the other requirements around distancing, symptom screening, other pieces. And I think many of us have noticed that in our conversations, things we are already familiar with can be really helpful tools. So a good example when we're talking about these ways of screening is the work from Wilson and Younger in the 60s that's been adapted over the years. And they sort of said that screening sometimes seems deceptively easy, but it's far from simple. And they talked about criteria to consider as part of a program or approach. And so these include things like there being a need for it, which we know, the objectives being clear at the outside with a defined population, that there be quality assurance within the program, and we try and evaluate these right from the outside, but mostly that overall the benefits should outweigh the harms. So this is another resource I'd encourage people to take a look at, particularly if they're involved in designing these programs or trying to understand why some decisions are getting made certain ways. And the evaluation piece is tough, and I'd be the first to say I worry sometimes that I don't do this enough in my own work as much as I would want, and we're very focused on doing, and it's hard to keep in mind that we should always be evaluating, and we need to be brave enough at times to stop doing things that aren't helping us in order for us to free up that capacity to do other things. And these evaluations can consider the impact on the clients or public or patients, on the providers, the outcomes we've achieved, or the costs. We can look at numbers like the proportion that accept or decline testing, what the test positive rates are, how many positives, negatives, and determinants we've had. But we can also look at qualitative information around how these programs are going, while throughout, and that may be a better way for us throughout to look at the ethical and equity implications. I think an approach many of us use around assessment, planning, implementation, and evaluation as an iterative cycle, I think can really help us when we talk about testing. So I'll come back to this list. I think maybe just to make a comment that I know so many are working really hard in how we do all this testing, and recognizing there's a lot of pieces to put into place. And so one thing to consider doing is if we're looking at a specific test to use or a new test to use or a new context, to sort of run through these factors and think about how we've applied it. We won't do that today in the interest of time and looking forward to the questions and discussion, but there's ways in which we can prepare these programs to be really successful and really help us contain this pandemic. So I really appreciate the opportunity to talk with you today about testing and to be a part of this webinar. I agree with the framing of talking about how we implement these. How do we go? We're going to be using these technologies in some way, shape, or form. So which ones and how and when? I do want to flag that there's tools that can help us with making those decisions and expertise within the public health system that as well as within healthcare and laboratory that can all work together as we do this. I do want us to be mindful of the differences between one-on-one healthcare and public health and population health approaches. What happens in clinics and hospitals is really different from a population health approach looking at a large group of members of the public or population, and both are valid and relevant, but they're very different. And I'm hoping we can keep in mind the work beyond the test itself around training and certification, the tracking, and other pieces. For those that are interested a little bit more in the public health population health approach, looking up Jeffrey Rose's strategy of prevention and thinking of how it applies to the COVID-19 pandemic overall. and also how it applies to these testing conversations may be something of interest. So thanks so much for the opportunity to be a part of this presentation today. My contact information is there. I'm happy to be reached out to with questions. And I'd like to, again, acknowledge the thank you to all those who've been working really hard through this response, all those following the guidance and recommendations as best as we all can, and the importance of all of us staying kind and respectful to each other through this. It's sometimes hard to do and easy for us to feel incredibly stretched, and so I really appreciate all the efforts on that front.
Thank you very much. We are now going to begin the question and answer session, and I would ask Dr. Poliquin and Dr. Pawa to unmute and share their video so we can get back to the some of the discussions following the questions. So the first question is for Dr. Poliquin, I guess. Is the biosafety cabinet required to prepare and for sample processing for the POC systems that you've mentioned today?
It's a good question, and it's a bit variable depending on the system itself. So a good example would be that the GeneXpert device, for instance, generally does not require a biosafety cabinet, but the BioFire device that was pictured in the same slide is authorized for use in a laboratory setting. So part of it depends on the system itself, and part of it depends on how much manipulation of samples you're going to need to perform. So it's variable, and the Center for Biosecurity, which is a part of the Public Health Agency of Canada, does an evaluation of these tests as they come to market to provide some guidelines around how to safely deploy them.
Excellent, thanks. And in terms of the point of care PCR-based tests, how do they compare to the in-lab formal testing that is done using PCR?
It's a really good question. And there again, there's a bit of variability. So a lot of the assays are actually fairly comparable to in-lab PCR, but not all of them. So it depends on the setting and depends on the device. But in general, point of care PCR tests are quite comparable to in-lab tests. The difference is, the main difference in terms of performance is tests done in lab are done by trained technicians. The results are reviewed. And so if there's any problems around the sample quality not being up to or not being great, or there was a delay in transportation, for instance, all those things can sort of be troubleshot, I guess, a little bit easier in that setting than in the point of care where the machine does all the work. So that's probably the biggest difference.
Thank you. With the new variants becoming more of a concern, what is the best approach for variant surveillance and testing, and how are we doing it currently in Canada?
So variant screening obviously is something that is very important, and there's a considerable amount of thought that's been put in this space recently. So in Canada, we have about a sequencing capacity of about 5%. The question of whether you need more sequencing or less is probably only half of the question. The other piece is how quickly can you get a sequencing result so that you can act on it. So what we're working through with Canadian public health labs as well as some academic partners is to try and both increase the amount of sequencing we can do and how fast we can do it. The other approach, though, is once a particular variant becomes established, for instance, the B117, also referred to as the one first identified in the UK, has some characteristic mutations. So once that's been sort of discovered and validated, you can make your conventional type PCR against these mutations to allow for rapid screening. And both of those approaches work in tandem. One allows you very, very quick responses, but doesn't give you the full sequence. The other piece gives you that full sequence so you can do the full analysis, and both of them work together.
Excellent. Are there currently any tests approved by Health Canada specifically for testing in asymptomatic patients?
So that's a good question. I have, for specific screening in asymptomatic patients, I don't believe so, but I'm not the regulator. What's more important in the question of asymptomatic screening, and Jasmine may have some thoughts on this too, is more how you're taking a test and how you're going to interpret your result. Because you can take a test that's authorized for use in symptomatic patients and test someone who's asymptomatic. That's something you can do. But if you're doing that, then you need to be really aware of the limitations of your test so that you can interpret the result and then take action on it appropriately. And so with that, maybe I'll turn it over to you, Jasmine, for the public health perspective on that.
Yeah, thanks, Guillaume. And I agree with your comments that I'm just trying to think in case I've missed one where that has been included, but my understanding is no as well. And there's reasons for that. As Guillaume's saying, it matters who you're testing, how we interpret results, and a lot of our understanding of testing comes from understanding their performance in people who are symptomatic and early in their illness. And it's a really different circumstance if we're talking about screening and asymptomatic individuals, and understanding how those programs might be built, and where we're helping and where we're not, and where that capacity needs to be used elsewhere to help contain this pandemic. Dr. Keenan, I'm wondering if it might be a couple other thoughts on the variant and tracking a variance question. Is it all right to share that?
Absolutely.
Yeah. So I think that I think that working with the lab teams, there's a lot of people working really hard on how we understand how much sequencing we're doing, how quickly we're getting results. I think some questions that come up too sometimes are, how do we best understand any implications of changes we do find in the sequencing, and how do we know what's a variant of concern, how it may impact testing and other things, and how do we make decisions about where the information is being shared and do that in a timely fashion. It's not always easy to do those pieces. And I think the other question that comes up sometime for me, which is maybe a bit of scope for this conversation though, is what are the implications of those sequences for our public health measures and the follow-up needed, and how does it impact our case and contact management? Thanks.
Excellent, thanks. And maybe Dr. Powa, another point on some of the use of antigen testing for public health purposes. So what are your thoughts about the limitations for screening on a broader population base using the PanBio and other antigen technologies?
Yeah, so I liked a question I think I saw in the list around how do we convey some of these subtleties, complexity, considerations around testing, because at face value, it seems like it's a no-brainer and it makes a lot of sense. As laboratory public health healthcare teams work on rolling out these programs, though, it becomes clear that it's not so straightforward, and that we can roll out things that aren't going to help us and take that capacity away from things that will help us contain this pandemic and move back to versions of our lives we recognize more. So I think that, I'm just taking a moment to gather thoughts, but I think we're recognizing that these types of screening programs or targeted testing to identify if we do have a cluster somewhere and trying to work out what's going on do play a role. But it's in specific circumstances, under specific sets of criteria, in a way that makes sense for public health response and healthcare testing. And it's not as obvious as it seems. So I really like that question around how do we convey this as people who all work in this space. Many of us on this call will either work in healthcare sectors or public health sectors. How do we convey that in a way that makes sense? And what part do each of us have in conveying that information? And it's not an easy question. I know as an organization, PHPC is trying to do this. I really look to the expertise of the NML and what the Public Health Agency puts out, but we probably have more to do on that front to convey what the best way to dedicate our energies into testing are. I think we've got more to learn on that front.
Thank you very much. This is a question to, I think, for both of you. As more of the population gets vaccinated, how do you anticipate that that will change how we use testing? Would antigen testing would still be useful, or would we get rid of some of those testing modalities, or how do you see it transform? So I'll let both of you take a stab at that.
Sure, maybe I'll start and then I'll turn it over to you, Jasmine. So I think, so testing is obviously going to change once vaccine comes out. It can change in a couple of dimensions. So one of the types of variants that we're really, really keen to find are ones that might reduce the effectiveness of vaccines or make you more likely to become reinfected. So we want to target those types of scenarios to a PCR test to allow for that sequencing to happen. But fundamentally, if we're still in that trying to diagnose people and get them linked to care as quickly as possible, the antigen tests still have a role to play in that area. So I don't foresee that the antigen tests will have a significant decrease necessarily in their potential use. It's more that we would want to be very thoughtful about which types of clinical scenarios we apply an antigen test to a PCR test so that we can do a bit more of that surveillance work after the fact. And then there's the question of what happens with serology, because routine serological testing can't distinguish between a vaccine response and a natural infection. But some of the fancier or more involved assays can. And so then we have to change how we potentially approach serological testing downstream to figure out what is vaccine, what is natural immunity, and does that matter? Jasmine?
Mm-hmm. Yeah, and I echo the thoughts. We get the question a lot around if, and have been in the last couple of days around if the vaccine's likely to interfere with the test results or interpret the need to be interpreted. And my understanding, and I'll leave with Guillaume to correct me if I've misunderstood parts of this, but that is for our PCR or antigen testing, not so much, but for serology, yes, and it's something we need to keep in mind. I think that, and the question was around vaccination and testing. So I think it's going to depend a lot on uptake, and it's going to depend on some things we don't yet know about vaccine. And I'll encourage people to continue to stay, to follow what NACI's information and what comes out. But we know things around vaccine in terms of preventing moderate severe illness. We're still trying to better understand how the vaccine links with transmission and what role it plays there. And so I think that there's a lot we still don't know, and it's going to depend on uptake. If we don't reach certain levels of vaccination, then we're going to still be doing a lot of testing, a lot of case and contact management as we are right now.
Thank you. And I think some of the answers are going to come with countries that have had wider deployment of the vaccine. So we're already seeing some of the results. So I think we will have those coming. The next question is regarding Abbott POC. Can it be used for asymptomatic? What's the sensitivity there? And what are some of the considerations when you're testing essential workers, such as in armed forces, when they're asymptomatic? Would that test be reasonable to use, or would you recommend other tests?
That's a really good question. So generally speaking, getting back to that previous discussion around the use of any of these tests in an asymptomatic context, it's really dependent on what you're going to do with the result. So these tests, so antigen tests, ID now, PCR tests, are generally able to pick up people that have, a viral load. Usually, the higher the viral load, the better they are able to detect that viral load. And we generally think that a higher viral load correlates more with infectiousness, which is oftentimes what people are trying to avoid, having someone that's infectious come into a particular environment that's critical. So, generally speaking, that's the thought process behind asymptomatic testing, because the only thing that an asymptomatic test tells you is whether or not at the moment of the test, it can detect the presence of virus or not. 6 hours later, 12 hours later, 24 hours later, if you're incubating the virus, you could become positive when you had previously tested negative. So it's a single point in time, and you have to treat it as that. And you would choose the test based on kind of how quickly do you need the result, and what type of action are you going to take? Is it that you're going to be safe to work for that shift that day, versus are you okay to work in a long-term care home where the stakes might be different if you happen to infect someone else? So there's a lot of decisions that go into that aren't strictly tied to the performance of the test itself.
Yeah, and if I can add in a couple of comments on that one, I echo that, and I think this is a really good example of asymptomatic testing as part of a program that's thought through some of the implications and outcomes. And so I think that we have choices in using these testing technologies, and we can use them. We can stick to PCR, we can shift to the cousin, the ID now, or we can move all the way to PanBio type things and use antigen testing, recognizing that we are going to have a drop off in sensitivity and what we'll pick up. But I think what we lose in this conversation sometimes is also it's not just about the infections we might miss, it's about the false positives, especially if we're in a situation where the pretest probability is really low. There's no outbreak happening, these people are asymptomatic, they're not a known contact. There will be some false positives that come up in that setting. And so I think as we do these, it's really important to know how the change in testing technology or the decision on it will impact those outcomes, and have plans in place. So knowing, okay, what extent of follow-up are we going to do off the PanBio antigen testing, for example, or what might we do with the PCR when it comes back, and recognizing that we want to move quickly. So it's reasonable to look at these options, but a lot of kind of underlying factors to consider.
Thank you. Are there ways that you think that the testing technologies can be combined in people who are previously positive to differentiate between prolonged PCR tail and new infection?
That's a really good question. There's a lot of work done in this space to try and figure out how to best combine or leverage tests and it all depends on the outcome that you're trying to achieve, right? So in general, and the Public Health Agency of Canada put out some retesting guidelines as well, and they're available on the FAC website if people are interested. Generally speaking, it's not recommended to retest someone by PCR because for the first 3 months following recovery, because we know that the tests are really sensitive and you can get a small blip of positivity out to 3 months. Antigen tests won't have that same phenomenon because they don't amplify. But that doesn't mean that we have observed some reinfections within the 3-month period. So there's a bit of sort of clinical decision-making that goes into that question. If you have someone that you think might have been reinfected, then you might still want to do a PCR test. You can consult with your local laboratory. They can look at things like the cycle threshold number and point you in the right direction and help with a bit of that additional interpretation. And then sequencing is another option for these to try and differentiate. Is that just the same infection that persists, or is that something new? So there's different approaches, but yeah, if you're interested, there is a pretty good, pretty comprehensive guideline put out by FAC on the question.
Excellent. I think I will take a last question because we're coming to the top of the hour, and the last question is related to would there be any public health benefit of sequencing more than 5% of the samples for detecting the spread of variants? And maybe as a part B of the question, how do you use surveillance in water systems? If you can have a brief comment on those, and I think those are both maybe for Dr. Powa.
Yeah, I understand that Dr. Poliquin has to leave in just a minute, so I just wanted to see, was there anything you wanted to share as last thoughts, Guillaume? And I can answer these.
Well, so I think on the sequencing piece, it's that combination of sequencing rate, but also time to sequencing that's really important. So the 5% is neither here nor there. I think it's capacity and timeliness working together. On the wastewater piece, there's lots of exciting stuff in that space, and I think Jasmine is quite familiar with some of the findings. So I'll turn it over to you.
Sounds good. Thank you. So the surveillance, the wastewater. So it's of interest. It's happening in parts of the country. I think it's a really interesting one for us to explore and could be of help. I think we need to be mindful of different contexts in different parts of our country and how our wastewater is treated. It's not a uniform, like you guys will notice a number of caveats to lots of my responses. And I think the other thing we need to be really mindful of with this type of testing is to be looking at trends. So these are not one-offs. These are things where we monitor trends over time. We consider it in the context of what we know of the COVID epidemiology in that area and really build it into our existing processes. But if we have follow-up conversations or webinars, this might be a really good one for us to look into more because we can draw on the experience in a couple jurisdictions. I did just want to sneak in one last comment as we wrap up, is I know a number of people have asked around specimen collection and NP versus nasal versus other. And my understanding is that we do know sensitivity may drop off as we move to oropharyngeal and others, but we are starting to see more use of nasal testing. So NP remains the main, nasopharyngeal or NP testing remains the mainstay for PCR testing and the majority of what we're doing. But with some of these antigen and lab testings, we're starting to see nasal perhaps being a reasonable option as well. And there's a mix of things, again, happening in pilots and programs across the country. So I'll turn it back to you, Dr. Keenan.
Thank you very much. Yes, and there's a promise with the saliva of some of the tests that are coming as well, but we will cap the questions and answers at now. And I want to thank on my behalf on the NCC ID team that has worked hard to prepare this, the Public Health Agency colleagues, and especially Dr. Powa and Dr. Poliquin for the excellent presentations. Thanks everyone for joining the webinar. NCCID and the Public Health Agency will continue to have webinars on COVID-19 topics. For more information as well as past presentations, please visit our website at nccid.ca. With all of that, please fill an evaluation when you leave the webinar. It's very important for us for future planning of our webinars to try to address the questions that we were not or are coming in the future. Have a great afternoon.